for joining us today. As always, the DC Chamber of Commerce appreciates your support and dedication to our organization and to the entire DC business community. Our goal is to always provide value for our members. And I believe you will leave here today with some tremendous insight around the issue of healthcare reform and, more importantly, around the DC Exchange. Let me thank Arnold and Porter for hosting us today. I don't think our board member, Richard Alexander, the managing partner of ANP, is in the room, but we thank them for being our host today. Now, most of you know that this is the DC Chamber of Commerce's 75th anniversary year. Well, I am pleased to tell you that today is the actual date of when the Chamber first opened its doors. So this is an extra special. Now, I am pleased to welcome to the stage Helena Folks, the Executive Vice President and Chief Healthcare Strategy and Marketing, that's a mouthful, for CVS Caremark. They are today's Legislative Forum sponsor, and Helena, thank you so much for your support from Mike and the whole CVS team. We're delighted to have you a part of the Chamber and to have you here in our city today. Please welcome.
Good afternoon, and welcome to the Chamber's second Policy Forum of 2013, Navigating DC's New Insurance Exchange. As Linda said, I'm Helena Folks, and I won't repeat my title, but I am honored to kick off today's event, one of 3 policy forums marking the DC Chamber's 75th anniversary. Before we begin, I'd like to acknowledge the mayor of this amazing city, the Honorable Vincent C. He and I had the opportunity now twice to have a fist bump, so I will never forget. And I'd also like to thank the 2 sponsors who made this event possible, Care First and the DC Department of Small and Local Business Development. Later in the program, we'll have time for Q&A. So please, if you have questions, write them on the cards that were provided, and folks will be around after the panel discussion to collect them. This type of program continues the Chamber's rich tradition of providing value for members and the entire DC business community. CVS Caremark is proud to be part of that community. Today we have 58 CVS pharmacy locations here in the district, a specialty pharmacy, and 4 Minute Clinic facilities. And we've also provided free health screenings to the nation's capital for years, which has included comprehensive flu shots. On a personal note, I have to tell you that DC feels like a second home to me. As someone who's leading CVS Caremark's healthcare strategy efforts, I oversee all of our public affairs activities, so I'm here in the district with great regularity, spending time over on I Street with our great government affairs team. As you can imagine, with all the changes that are happening in the healthcare landscape, we've gotten to know each other pretty well over the last couple of years. And yes, healthcare is indeed evolving, and so are we. The retail pharmacy side of our business is now an important element of a much larger Fortune 13 company, one that includes a pharmacy benefits manager and a retail clinic, which is aligned with major medical systems throughout the country. The breadth of our business is becoming increasingly relevant as future changes in the healthcare space take place. I was reading an article on healthcare exchanges that ran in the Hill newspaper last week. The reporter was citing a recent Kaiser Family Foundation poll conducted in April, which echoed our own research. They found that 4 in 10 people were not even aware that the ACA is still a law and is actually being implemented. If that is true, it's pretty shocking. And you consider, broadly speaking, it would mean about 126 million people in this country don't have the slightest clue that in exactly 98 days, the exchanges are set to open, and everyone is not only expected to, but required to have health care coverage. What this reporter wrote after that, though, really struck me. These factors pose a challenge to supporters of the law over the next 6 months as they prepare for the start of enrollment. I actually disagree with that. These factors pose a challenge to everyone, and we think we can help. I'm willing to bet there isn't a federal office building in this city that sees 5 million Americans every single day, but we do. In fact, a CVS pharmacy is located within 3 miles of 75% of the US population. So due to our community-based business model and geographic reach, we have a unique role to play in raising awareness around implementation of the healthcare reform. This is a question asked across 7,400 pharmacy counters countless times a day. So what do I do now? And we pride ourselves on having answers, whether for seniors back in 2006 with Part D enrollment, or now regarding their questions around enrolling under the ACA, or for a busy mom who's managing the medication regimens for a multi-generational family, or for a young person who needs help managing his diabetes. And I'll conclude by saying, you know these people. They're your family members, your friends, your colleagues and neighbors, and your employees. We're working hard to create awareness-building programs that will result in all of them knowing that when it comes to the exchanges, we're prepared to help people cut through the confusion. We've been a trusted information resource for the past 50 years, and in an era of change, that's one thing that will not. So now it is my great pleasure to introduce Tanya Vidal-Kinlow, Vice President, Government Affairs for Care First, Blue Cross Blue Shield, who will introduce us today's panelists.
Superman, my superwoman ring. I had to hit him twice. So thank you, Helena. I don't know about you, but I'm pretty excited about the conversation that we're going to have here today. I think this panel is going to bring to you a lot of important information about healthcare reform and the healthcare exchanges. And as Helena mentioned, the DC Chamber presented a policy forum last year on healthcare reform and the impact that it has on your businesses. In fact, that policy forum was at Care First headquarters here in Washington, DC. It's hard to believe that it's been a year already, and that means that we're even closer to the launch of the healthcare exchanges and the implementation of the Affordable Care Act. Today's discussion, while focusing on the most effective ways to navigate the new exchanges in DC, will overlap into several areas of healthcare reform. The panel will give you the knowledge you need to make sure that you're ready for the implementation of healthcare reform and have modified your business strategies as necessary. I'm hoping that you'll feel free to join the conversation by using the Twitter hashtag DC Health Exchange Forum. And now I'd like to recognize today's distinguished guest panel, a special group of business leaders that will provide a clear and thoughtful discussion on today's topics. They include Mr. Lee Bethel, who's the president of Comprehensive Benefit Services, Inc., Mr. Chet Burrell, the president and CEO of Care First Blue Cross Blue Shield, today's presenting sponsor, Ms. Kim Horn, president of Kaiser Permanente of the Mid-Atlantic States, Ms. Mila Kaufman, director of the DC Health Exchange Authority, Ms. Lynn M. Petty, principal and legislative compliance director of Keller Benefit Services, Ms. Denise Cora Bramble, the chief medical officer at Children's National Medical Center. So as you can see, we've got a talented panel of presenters with some very impressive credentials in the room today. And speaking of leadership, and someone whose voice is definitely worth listening to, please join me in welcoming a very special guest. He's become a fixture at the DC Chamber Policy Forums, and he is someone with great knowledge of this subject and will play a key role in healthcare reform implementation. Please join me in welcoming the lead presenter and panel leader of the discussion today, the Honorable Vincent C. Gray, Mayor of the District of Columbia.
Thank you very much, Tanya, for such a nice introduction. And the moral of that story is, as hard as they may try, they cannot get rid of me from these public policy forums. I actually thoroughly enjoy coming. It's a great way to keep yourself, edified in terms of the issues of the day. And I really want to congratulate the Chamber. I want to congratulate the CEO, Barbara Lang, for doing this and keeping the topical issues before people. One need only look at the size of this audience to have an appreciation for the regard for the topical nature and the importance of these issues. And I think they've all been like this. We've been over at the Reagan Building, we've been at other law firms, we've been around. And every one of these, they have been extremely well attended. Just a couple things before we really get started. I want to congratulate the Chamber on its 75th year of serving the District of Columbia. And obviously, like you, I didn't know every one of the CEOs of the Chamber, but I have a feeling that none is better than Barbara Lang in the leadership that she has provided to this organization. Thank you, Barbara, and I hope this is a great opportunity for us this year to be able to salute the leadership that you brought to this organization as certainly in the lead of representing businesses here in the District of Columbia. Thank you. If I could take another, I won't say shameless moment because I want everybody to share in this. Did you all get one of these? They should be floating around. If you didn't, I'm sorry. But anyway, this is something that we decided to put together because there are lots of things that are named across the nation. Cities are looked at, states are looked at. And so we've been getting, over the last number of months, we've been getting named to one or another thing. So we decided to put this into one place called Why the District of Columbia is the Place to Be. And I want you to know that the things that are listed here are not things that we had anything to do with at all. And just to call it to your, call some of them to your attention, did you all know that we have the strongest economy in the United States at this stage? Can you believe that? The District of Columbia has the leading economy in the U.S. We're number one in the U.S. for LEED certified buildings, according to the U.S. Green Building Council. We're the number one new tech hotspot, according to Forbes magazine. The number one retail market on the East Coast. I know, Barbara, that is music to your ears, given what the Chamber has done to help promote that. We're number one in the U.S. for best cities for college graduates, best educated city in America based on the degrees that people have. And if you turn over, one of the things I'm especially proud of is that Harvard University gave us the Bright Idea Award for our One City, One Hire program, which has now gotten back to work about 6,500 people in the District of Columbia with over 900 employer partners. We just got this news last week that we have reached number 10, which is the first time ever in the history of the city, I think, in venture capital investment in the District of Columbia, and we will be striving, of course, to raise that. Number 2 in the U.S. for real estate investment. Number 2, fittest city. We just found out we are number 4 in the nation in construction activity. That is Forbes magazine. Number 6 in the nation for parks and recreation services. And the number 2 hippest U.S. city. I'm not absolutely sure what it means to be the hippest city in the U.S., but you know what? I am so competitive, it doesn't matter to me. I am completely focused on who number one is. Number one city, we are coming for you. We found out that it is Houston, Texas. Now, I know we're more hip than Houston, Texas. Come on, y'all. I'm sure they got a lot of good things going on in Houston, but they don't have it going on like we do in the District of Columbia, you all. No, I am taking the opportunity to talk about this a little bit when I go various and sundry places, like most of them. But one of the reasons is because I honestly think that we historically have suffered from low self-esteem in the city, that we allow ourselves to be convinced that we aren't all that good, that there's always somebody on some issue that is better than we are. And I happen to think that that's not true. And frankly, being able to feel like being number one in part is how you feel about yourself. And I do think that we are number one on lots of things. We now have affirmation of that in a number of ways. And I hope that when we go to these, especially national meetings, you know, not to suggest that we ought to be into the braggadocio mode, but that we would let people know that the District of Columbia is really tops in so many things. There's only one low number that I would like us to be able to aspire to, and that is the number 51. And that is becoming the 51st state in the United States of America, which I think we ought to be. Thanks to Harry Reid for having said that last week. We're going to work with him to try to get a hearing on that bill that is pending before the Senate, and I hope that everybody will join with us in making that happen. We are here today to talk about health care. This is not the first time we've talked about health care, and we're going to continue to do that today. We want to welcome everybody to the Chamber's Policy Forum, and I don't have any doubt this is anything like any of the discussions that we've had before. It will be an open and frank discussion, especially as I look down at some of the panelists, combatants, we have with us today. I probably won't need to do anything but, you know, keep apart from one another. It really is a unique opportunity for lots of folks, a great cross-section of the people in this city, to be able to talk about one of the hugely important issues here in the city. And you've heard from them. I'll mention their names again, probably a lot during the presentation, but they are a diverse group of professionals who are participating in the panel today. It hardly seems like 3 years ago that the Affordable Care Act was adopted. In fact, it's more than 3 years ago. It was in March of 2010 that the law was adopted after much controversy, after much debate. You know, one of the things that can happen to you if you live in this city, you kind of think that everybody is tuned in on everything. And then you hear that statistic, like what was it, 40% of the people didn't even know that the Affordable Care Act is still an act that is still, you know, it's still moving us in a different direction in terms of health care here in the nation. Mila and I were doing a show for Inside One City last week. And what was it, probably around 30% that we talked about then, 30% or more, who don't seem to have any awareness of the Affordable Care Act and what its implications are. It really is probably the most significant overhaul in healthcare that we have seen in decades, certainly, and maybe ever in this country, because it begins to get at what is a gnawing issue, which many people don't. Nobody would disagree that everybody should have health care and health care coverage, but not everybody agrees on how that should be done, as we saw during the debate around the Affordable Care Act. The law guarantees access to care for most vulnerable populations. Now, one of the things that we should be cognizant of here in the city, which you probably are already, is that we had come close anyway. We had been first in the nation, second in the nation in covering adults. I think we had something like 93% of our adults who were covered, second only to Massachusetts, which I don't know if you followed that debate during the presidential campaign, but I thought that one of those candidates was responsible for Massachusetts having health care coverage, but didn't seem to own up to it during the discussion. But you know how these things go, right? The amnesia is still alive and well. And also in terms of children, we are first in the nation. We have about 96% of our children who are covered, which of course raises an interesting question too. When we talk about HealthLink and health benefit exchange, does the district really need a health benefit exchange if we're all that close to covering people? Or the 40,000 people who plus, would they have gotten coverage otherwise, and would they still be part of the uncompensated care numbers here in the District of Columbia? Health plans will be made available in 4 tiers, is that right? Or 4 levels, I guess we might say. And we're anxious to hear about that, how that will work. People will, I think, enjoy a lot more freedom over making their choices. It's interesting, we saw it today where one of the firms, one of the companies going into HealthLink looked at some of the costs being offered by some of the others and came back and said, we want to lower our costs by 12%. And that, to me, is an affirmation of one of the benefits of having the health care exchange and having this kind of transparency in the first place. So again, I want to thank the Chamber for bringing us together and being able to forge these kinds of partnerships across the city to discuss what is truly a key issue. There are some states that have opted to let the federal government run their exchange. We didn't do that. We are running our own exchange. The council actually adopted back in 2011 the establishment of an exchange here in the District of Columbia. It was legislation that we advanced, and then we've been working ever since with the board and with Mila, and I want to thank her for coming on board to take this position. You can learn more about her background if you wish, but she really has a storied career, having been the superintendent of insurance in Maine, right, Mila? And we thank you for being available to work with us here in the District of Columbia. So what I'm going to do first is ask each of our panelists to make an opening statement. And I know that the tried and true approach would be to just go down the line. But you know what? Then people will sit there and say, I know when I'm next. This will keep people alert, Barbara. Never know when you may be picked. So I'm going to let, since you are heading the exchange HealthLink, I'm going to let you go first, Emil, and then we'll jump around a little bit, and then we'll jump into questions. And then, by the way, I hope you all will be noting your own issues and questions, and we will ask you to weigh in at some point, right, Dave? You'll let me know when that moment comes too, won't you? I know you always do, so thank you. All right, Mila. You have 32 seconds. Why don't each of you take, would 2 minutes be okay? 2 minutes to make an opening statement, and then we'll go from there. How's that?
Perfect. Thank you very much, and thank you, Mr. Mayor. It's because of your leadership and your strong commitment to this city that we have the second lowest uninsured rate in the nation. It's because of the investments that you've made through your career in people here and expanding access not only to coverage but also to care. So thank you very much. It's an honor for me to be here with you today. I also just wanted to thank Barbara Lang and her whole team. I'm very excited about the new partnership that DC HealthLink, that's our new name for the exchange here, DC HealthLink, you heard it here first. We have partnered with the DC Chamber of Commerce to help us educate small businesses and large alike, as well as individuals, to help spread the word about the Affordable Care Act, as well as the new opportunities that small businesses especially will have here for more affordable health coverage options, new choices, and price stability. So I'm very excited about the new partnership and just wanted to thank you very much for your leadership around that. I would just say that I've been in the health policy world for a long time. and have worn many different hats. And I actually didn't think I would see the day when we would have real health reform, where there's a strong, strong possibility that we will actually achieve near universal coverage for all people who live and work in America, where everyone who needs insurance will have it, where everyone is paying into insurance to make sure that it's affordable and stable. No more the days of women getting charged higher rates just because of gender. No more the days of people being shut out of the private market if they have medical needs or their medical needs not being covered. No more the days of people going into bankruptcy because they thought that they had real health insurance, and when they really needed it, it wasn't there to give them the financial security they need. So I am so excited to be a part of history, and I know that working with all of you, we will succeed in covering most of our population. We will succeed in making sure that small businesses can thrive and that the pressure of the premiums on them is lifted. And I know that closely working with you, we will succeed, and we will have a much better financing system. It will be sustainable and affordable, and everyone will have good coverage and access to medical care that will save their life someday. So it's a pleasure for me to be here, and I'm excited to answer any questions you may have.
Thank you, Mila. Lee Bethel.
Good afternoon, Mr. Mayor and everyone. It is a pleasure for me to be here today. I viewed my role here today as to provide as a broker, because one of the things that we do at my company is we assist businesses in securing health coverage presently. And with the advent of the healthcare reform, it is going to be vitally important that a clear understanding of all the new regulations, the rules that are going to be in place are understood by you as employers, those of you who are individuals, also how you access care, how the exchange will be of benefit to you. So my role here today is to answer and field any questions that you have on that aspect of how things will actually be done. The notices that you need to send out to your employees if you're an employer, how do you select coverage, how the exchange will work, and how we will interact with you to assist you in having the implementation of a successful transfer to the exchange.
Thank you. Kim Horn.
Good afternoon. It's a pleasure to be here.
Afternoon.
I just want to echo the opening remarks that the mayor made, and that is that the Affordable Care Act is the most significant piece of reform that this country's ever had on health care. And we're all here today because we're trying to figure out the navigation of what it means to small businesses and individuals. But I agree that everybody agrees that something in healthcare needs to change, but none of us really want to individually change to make that happen. But it is, the current system is unsustainable. I mean, the reason why we're talking about that is an economic issue. People can't afford coverage anymore. The fact is, the data is very clear. The quality outcomes in this country are abysmal, and that our fragmented kind of fee-for-service system, is not sustainable. So while today we're talking about, I think, 98 days to the launch of exchanges, I would say over the last couple years, the biggest changes in healthcare, fundamental healthcare reform has been undertaken. The first part was the expansion of coverage for folks like up to 26 year age. A lot of the insurance reforms, kind of standardizing insurance regulations, but most importantly, a lot of change around accountability, kind of reforming the healthcare system itself. And without this notion, everything from connectivity, encouraging organized systems of care, measurements, performance, things that you do in your own business in terms of outcomes. Without insurance exchanges or an open competitive market, a lot of the incentives to reform the underlying healthcare system wouldn't occur. So as we kind of think about this next phase of the exchanges, I'd characterize them as a public-private partnership. Public being, the DC chamber in this case, or the DC exchange is the public piece of it. The private is all of us, Chet and Care First and Kaiser Permanente, working with the public exchange to make healthcare affordable, giving people more choices, standardizing more of the offerings so they can make informed decisions. And I'd really encourage all of us that, we're in this moment of change, and it's really, really important that we work together to make this work. It's too important, healthcare to fail for this country. So it's a pleasure to be here and look forward to your questions and working with all of you small businesses to provide more solutions to your healthcare needs.
Thank you, Kim. Denise Bramble.
Good afternoon. It's a real pleasure being here. I'm actually looking forward to hearing from all of the panelists. So I know I'm one of them, but I really am looking forward to it. I have been in the District of Columbia for over 30 years and have been a practicing pediatrician. I have the privilege of being a chief medical officer at Children's National Medical Center, but still see patients. So my goal is to bring the clinician's perspective to this conversation. And also to put the sort of healthcare reform in context as it relates to the work that we're doing at Children's National. Focusing, we have always looked at and focused on quality, but much more so now going forward, and looking at our outcomes as it relates to not just seeing patients for the sake, just seeing one patient after the other, but looking at the entire continuum of care. And seeing what are these progressive and successful models that we can bring to bear in the District of Columbia. We've done great work in the past, and going forward, I'm confident that there's much more that we'll be able to do with a new healthcare reform law.
Thank you very much. Chet Burrell.
Thank you, Mr. Mayor. It's a pleasure to be here. I would echo much of what's already been said. I think what's interesting about the Affordable Care Act and the implementation of exchanges, there's many things that are interesting, but it creates an online market for health coverage that didn't exist before, and has been said, creates some standardization in the products so that it's easier to compare. And so the idea is a hard idea to argue with, which is people should be able to go and pick the coverage that best meets their need from the carrier that they prefer, and to do so in a market where there's competition on the price as there isn't any other market. We are the largest carrier in the district, covering somewhere between 80 and 100,000 people. Much of the private market has our coverage. I am a district resident, live in the district, love the district, glad it's number one on whatever, on a bunch of things.
Everything.
Yes. I would draw the distinction, and maybe we'll pick this theme up a little bit later, between insurance reform and product reform and healthcare reform. The underlying problem that the country has is the rise in healthcare costs. And why are the costs rising the way they are? And much of what is happening through exchanges doesn't directly get at that, although it is a very important element of the whole equation. We have the rise of chronic disease in the country and other things that are driving healthcare costs. So I would draw that distinction between insurance reform and healthcare reform. Also point out that one of the essential features that has strong, and always did have strong public support, was the idea, and Mila touched on it, what's called in the industry guaranteed issue, that if you want a policy, you are guaranteed to get that policy. You cannot be turned down. And it's an idea, it's a fundamental idea in getting coverage to the whole population. It has consequences on cost. And when we get into this a little more, I'd like to speak about that, of what those consequences might be. But it's an idea we strongly support. We have been not only involved in the district in terms of the coverage we offer to people individually and through small groups, but through a wide variety of charitable organizations that we give to, almost all of which, in one way or the other, support vulnerable populations that, were it not for what those organizations do, people would not have had access to the needed healthcare services that they seek. And so we're strong supporters of the principles behind ACA and about the need to have access for the whole population.
Okay, thank you, Chet. Lynn Petty.
Hi, like Lee, I'm also work for an insurance broker. We're based out of Maryland, but we have a lot of small DC employers as our clients. And at our firm, we have 2 people full-time working just to go through healthcare reform and what it means. And I would encourage you to reach out to your insurance broker or your agent. If you have a small group plan, you have one that's helped you write your coverage and manage your plans, and figure out what it means to you beyond the context of just HealthLink and exchanges. There's many different rules. We can spend 2 hours in my office trying to determine who's an employee, who's a small group, what's a full-time equivalent employee. So those are all things I think you might not get from today's forum, but that you'll need to go back to and work with your agent or broker, whoever advises you on your benefits, to figure out what this exactly means to you and your employees. And I'm happy to stay and answer questions afterwards as well.
All right. You all have been, you've been very professional and very polite thus far. And this is an issue for some that is very difficult to remain professional on, and certainly very difficult to remain polite, because it has been a contentious issue. Healthcare coverage has been a contentious issue for decades, depending upon what facet you want to talk about: uncompensated care, the cost of insurance, you know, what employers should do, whether small businesses should do more than what they do now. And of course, now we've injected the Affordable Care Act into this. So what I would invite you all to do is not just spoke off of me, okay? I ask a question, you give the answer. I ask a question, the next person gives an answer. Let's not do that. Let's just try to jump in, okay? All of you are very experienced professionals. And you don't have to wait for me to referee. I will do that if it winds up being the way to go, but all of you have strongly held opinions for very good reasons, and we want to hear that, and we'd like to see that kind of interaction with one another, okay? You know, the first question I will ask is, are you as astounded as I am to hear that 40% of Americans don't even know that this exists? How in the world is that possible? And, you know, not so much, I'm not asking you to tell me why it's possible, you know, because ignorance seems to abound, you know, no matter what environment you're in. But how do we overcome that? This is one of the most important issues in America at this stage. It has the potential to make America healthier if we use insurance coverage correctly. So how do we overcome that? I'm going to start with, let me see, I'm going to start with Lee, and we'll go from there. How do we overcome the fact that, you know, close to half of Americans don't even know this law exists? I don't know how high profile it could have been. Maybe that's because I'm inside the Beltway. That's what people would accuse us of. But what do you think?
I think that there's several different facets to that. One is actual communication and being in tune with what's going on. Even though we're in this world of social media, we have all these news outlets, we don't, many times individuals do not actually take the time to learn about something unless it directly affects them. So as time is moving forward, we're going to find...
But doesn't this directly affect everyone?
It directly affects everybody, but because the effective date, the open enrollment has not yet hit, everybody's not really cluing in yet. They're not doing the advanced knowledge. I would guess that probably around September, as people are now realizing that, oh, I've got to enroll in this, or I'm going to pay a tax if I'm on an individual basis, or if you're in a group and the group doesn't offer coverage, the employer is going to say, well, how does this affect me? And all of these things are now coming into line, so it's going to be a rush. I hate to say it's a lot of procrastination that I see as a reason why, at this point in time, there's not a lot of information going out. Soon there will be a media blitz across the board. You're going to have ads. We've got the chamber who is now going to be doing educations. We're going to have ads. You're going to see things coming in from the federal government. So this media blitz will hopefully address that over the next upcoming months.
Mm-hmm. You agree with that, Kim?
Well, I think that, yes, I do. I actually, that people generally aren't paying attention, but I'd also...
Disagree if you like.
But I think that's, part of it is healthcare is so darn complex that even if you were paying attention, you can't figure out. Then it's been so politicized. And I think the general individual would say, well, this is all going on, but all I'm hearing is it's going to be unaffordable, so even though it's going to be available to me, it's really not going to be. Every news article you see, it says, prices are going to go up 40, 50, whatever it might be. So people are pretty disillusioned. There hasn't been any really positive rhetoric about this at this point to really get people's attention. So maybe we're in this 98-day cycle and kind of all resigned that this is going to happen and can get, some positive, encouragement to the public about what that potentially means to them. And for us within the healthcare industry to say, what are we going to do to make it work? What are those real, the solutions that we're going to bring to bear to make sure that it's not only available to you, but you can actually afford it. And maybe put that price into context with the rest of life's, price tags, which is maybe another topic for discussion. So,
Denise, you work at an institution, if you permit me to call it that really by definition, has a hands-on relationship with lots of people, children and their families. Are you struck by this number? Does it disturb you? And what do you think, from your perspective, we can do about it?
I'm not really struck by the number because I remember when we went through the experience with the Children's Health Insurance Program that it was available to families, but families didn't always sign up for it. And across the country, there were many examples of states that struggled with that. It's like, here it is, just come and get it. And those institutions have had to use different approaches. The question is, where are we communicating? Where are we delivering the message? And we have to be at the community level. So from my perspective, we have to use sort of the, parent navigators and promotores de salud to be able to take that message to
What's a parent navigator for those who may not know? So once I heard 40%, I'm taking nothing for granted anymore.
So I'll give you an example. At Children's National Medical Center, we have a program called Parent Navigators Program, where these are parents of kids with special health care needs that are helping other parents of kids with special health care needs navigate through the healthcare system. It was already mentioned. It's a complex system for, those of us who live and breathe it every day to understand it and to really grasp all the nuances. So we try and break it down for the families. We try and make them understand what the issues are. The other thing that I would say is that we have to move closer to where the communities and the families are. We have to deliver this message in the churches, in the mosques. We have to go out there to make sure the message is delivered.
Can I jump in?
Jump in.
I did raise my hand.
There you go. You guys don't have to raise your hand. You just jump right in. Okay, you got the mics in front of you.
I have to agree with pretty much everyone's comments. Part of the challenge for us is first addressing the facts that are actually not true. Remember all of the political discussions about death panels and this and that? Well, they're still going on, and some folks don't see our information, don't see the fact sheets that we issue, don't come to our forums. So it's a real challenge to address some of the misinformation that is out there. Now, with that said, we recognize that there's a significant population segment here, not only in the district, but all over, that people don't have time to get all the facts, don't have time to invest a whole lot to figure out what ACA means for them. We recognize that. We also recognize that if I go out and speak, it is very different than if Barbara goes out and speaks to the small business community. So it's not only the message, but it's also the messenger. And we get all of that. So part of our comprehensive outreach plan includes partnering with trusted messengers. In addition to the chambers here in the district, we're going to be partnering with all the churches. And so at Sunday prayer, people may hear all about the exchange and the new opportunities to enroll. We're going to be partnering with community health clinics. So as people come in to get medical care, if they're uninsured, they'll have an opportunity to sign up to enroll. So we're thinking about what we need to do in a very creative and a very comprehensive way. And absolutely, when the time comes, we will be on the radio. You'll see DC Health Link in all of the, if you ever ride the bus or the metro, we'll be there. We're looking to partner with all of the sports teams here, me especially with the Nationals, now that they're doing slightly better. But we're going to be very creative, and I just want to add that Kim is absolutely right when she says this is really a public-private or private-public partnership. Without good partners like Care First and Kaiser and the other 4 carriers that are committed to making this work, we cannot do this alone. And that also goes to the education effort. We want to partner with all of the carriers to help us educate the small business community, the individuals, and people who work for large employers who are part-time workers who don't qualify for job-based coverage. We want to make sure that we are successful at reaching everyone who is uninsured and everyone who is underinsured, because all of that also contributes to some of the cost drivers and uncompensated care. And I would just say one other I'll make one other point that's not related to education. I do want to thank Chad for adjusting expectations. We at the Exchange cannot fix all of the problems, the delivery system issues, some of the inefficiencies. We cannot fix the cost drivers. So I appreciate the comments he made earlier. We can do a whole lot. When the market is restructured and there's more competition for your business and there's better quality coverage and there's comprehensive coverage and more affordable coverage for many, especially with the tax credits, the tax premium reductions that are available, we can do all of that. But we at the Exchange cannot get necessarily at the cost drivers, so it will take all of the providers and the payers working together to try to figure out how to really tackle the cost drivers.
When you say cost drivers, you mean of the healthcare services themselves or the insurance?
So when I say cost drivers, I mean everything that goes into why the premiums are so high for many. Mm-hmm. So when we go to the emergency room, instead of going to the primary care physician, it costs more. That's a contributor to the higher premiums. If we get the highest, the most expensive drug as opposed to a lower cost drug that's equally effective, that drives premiums. If we wait too long to get diagnosed for diabetes, and then we have high blood pressure and heart disease and all of the other things, if we wait too long, that contributes to the cost of care, which of course drives the premiums. So ultimately, once everyone is covered, we also have to focus on the underlying cost of what drives the cost of the premiums.
Mayor Gray, will add something to that. With reference to the idea of how health insurance works, most of us are under the thought process that if I have something to go with the health insurance, it's going to pay for it. I shouldn't have to contribute. I might have to pay a deductible, maybe a copay, but I'm really not supposed to have to pay much when health insurance, because I have health insurance, it should be covered. And in the era when we have 100% coverage plans, those plans then are able to fuel this rise in costs, because now the individual employee does not have to actually investigate, is this the best price I can get for this particular service? Can I get a prescription at a lesser level, because it isn't affecting their pocket? So one of the things that has to be done also is an education on how medical care is received, just as Mila was referring to, so that we understand now that there should be this partnership. You talk to someone and they say, I have a health insurance bill of $1,000, and why should I contribute to this? Because the health insurance is going to pay for it. So that's something else. The other piece to this is that something that I've been an advocate of was I was always for guaranteed issue. I've had many groups, small groups in the District of Columbia where there'll be a group of 5 or 6 people. Somebody will have diabetes, somebody's overweight, there's a maternity, and there's an HIV in the case, and they will now get what we call a HIPAA load. And the HIPAA load will take that rate, if they originally were quoted at $300, say for single, maybe $400, it'll take it to $2,500, which will make it unaffordable. While the insurance company could not decline the group, it is technically guaranteed issue. They can rate the case so that it's effectively a decline. That will end under healthcare reform. So many groups that have had medical issues or were not able to provide coverage for their employees because some of them had medical issues, whether it be multiple sclerosis, a variety of different things that were loading the rates, they'll now will be able to get care at a much more affordable cost.
I wanted to raise one issue in terms of the importance of the payers working with the providers as it relates to, this post-healthcare reform environment. They mentioned the issue of emergency department visits and how expensive it is. Well, we've been able to work with payers so that we have an emergency department to medical home project, which focuses on sort of the patient-centered medical home concept to make sure that kids are receiving the correct care at the appropriate location at the appropriate time. So it is important to partner, and I welcome more of those opportunities.
Let me just comment on a couple of things and maybe introduce a couple of facts. A couple of things to keep in mind. Under the Affordable Care Act, people can enroll through an exchange for a limited period of time, and that period coming up is 10/1 of 2013 to March 31st of next year. It's what's called an open enrollment period. So you have that period of time to enroll. A lot of people haven't focused on it yet, but when it comes time to actually understand that your coverage depends on you acting, we may see a lot of action around March 15th or something. But as the deadline gets closer, I think people will be galvanized to act. But here are a couple of interesting facts. We cover most of this community. Over 90% of the coverage we offer, people we cover, get their coverage through their employer group. Only about 8% get it as individuals. So one reason for the quietness, perhaps, is people are just assuming, I've got my coverage, I'm going to stay with my coverage, and I don't have to do anything. But here's a critical fact. If you imagine any population of people, this community or any other, divide the community into 5 bands, the top band being the most ill, and the bottom band being the most healthy. Well, just a couple of facts. The people in the top band that are the most ill, 3% of the population. 33% of all the dollars go to them. This is major heart disease, cancer, stroke, trauma. The bottom band, 50% of the people, 7% of the dollars. So in the bottom, where the healthy people are, the cost is about, just based on our data, $45 a month, maybe $500 a year. The people at the top, 100 times as expensive, $4,500 to $5,000 a month. So now you have an exchange, and you say guaranteed issue to all. Who do you get? Do you get more from the bottom or the middle or the top? Has a huge bearing on what it ultimately costs if you assume that the premiums equal the cost. Let's say they did, and nothing else, just the cost. It matters a lot then who comes in. And one of the things that the White House has been trying to do in concert with locally here with the exchange and everything else is to try to get young, healthy people involved. And you heard the concern about that. And if you don't get the young, healthy people involved, they leaven the loaf for everybody else. They bring down. If all you ever got were the people towards the top of the pyramid, you would price the product out of everybody's reach. You have to get younger, healthier people in. And that's typically done through social media, outreach, the way young people communicate. And that effort is critically important through the navigators and through other processes because that's where these young people really learn. And we've been ourselves tapped into a lot of the social media. What are they talking about? Misimpressions of things. And how would you create the correct information for them? Becomes critically important. But if the young people, healthy people, do not buy into this. And young, healthy males, unless their arm's falling off, they don't get health care, they don't think of health care. You know, they just, those are the people you want in. And that becomes critical to the success of this longer term. If only the sick come in, if only the houses that are burning come in, the insurance becomes unaffordable. And that remains to be seen, how that all goes.
I think that's the argument why the concern is that businesses will just exit the health care, you know, and I think that's the argument that would encourage you all to stay in, because I'm sure we'll have many more people covered if, in fact, employers stay in the game. So, you know, I think it is really incumbent upon all of us to try to make this work on the shop exchange and get as many people into, you know, having coverage as possible.
I could add just a couple of facts to that. Even though 90% of our enrollment is in small groups, 2/3 of all small groups don't offer any coverage at all today. 1/3 that do offer high deductible health plans, mostly, and because of the cost. But it's right. If the employer said, this is so expensive, I can't afford it, what they could say to their employees is, I'm out of here. You're on your own. Go on the exchange and get whatever coverage you can. And if you can get a subsidy, because you can only do that through the exchange, God bless you, get a subsidy, but I'm out as an employer. And if that happened, it would have a big consequence on the long-term sustainability of the whole idea. And that's something we'll all have to see together. You know, that's not something you can necessarily analyze your way to as a conclusion a priori.
And I just want to address that. We've made many policy decisions focusing on the needs of small businesses, and we've had a lot of input from many small businesses into our decision-making process. And so our goal is to make it as easy as possible for any small business to come and get insured for the first time, or get new coverage and offer workers more options than the small business is able to do today. In fact, because of our policy decisions, small businesses that come to us can offer workers a choice of insurance companies. So right now, if you're a small business, you pretty much have to decide, Kim or Chet. You can't offer both. And when you come to us, a small business can decide, well, I want to offer Kaiser, and I want to offer Care First, and I want to offer Aetna and United, and let my workers decide, why should I pick the best coverage for all of them? Let them decide. The small business can figure out how much they want to contribute. It's up to them. And then the worker decides which insurance company. If the small business likes the insurance company and wants to stay with a particular one, they can still give workers a choice of HMO or PPO or coverage levels. So we're making it as easy as possible for small businesses to come to us and enroll. And in fact, we're building a special web portal for brokers. So if a small business is currently working with a broker, the broker could come use the broker web portal and shop and place the business very quickly and easily. If a small business is not working with a broker, we will have a list of licensed brokers, and the small business can get that assistance and work with a broker, whether it's Keller Benefits or Lee or any of the other brokers, to get assistance to enroll. When I talk to small businesses, and I know many offer coverage now, and this is true whether it's a for-profit or a nonprofit small business, I hear all the time that it's unaffordable and I cannot afford the premium increases. And to afford the premium to keep offering coverage, I have to go to the higher deductibles. And I know it's not good for my workers and it's hard to retain good workers, but that's all I can afford. So that's what I hear all the time, and it's up to us to make sure that in 2014, small businesses have better options. And I do have to say that the rates that Kaiser and Care First and the other carriers have filed for the exchange products for 2014 are terrific, and in some cases, much lower than what a small business is able to get in today's marketplace. On the issue of getting all the healthy young people, I'm all for that, and we're absolutely devoting significant resources to get the Healthy Lives in. And I have to say, the prices that the carriers have filed for what is called catastrophic plans are phenomenal, as low as $95 a month. If a young person under 30 wants a catastrophic policy, if they want something better than that bronze level, $125 a month, either from Kaiser or CareFirst through the exchange. So again, I'll applaud the carriers for recognizing the need to price products in an affordable way to attract the young and the healthy into the market. And I'll conclude by saying that, remember the 3% that Chet mentioned? Any one of us could be in the 3% at any point in time. A catastrophic illness, cancer, heart attack, we're in that 3. So we may all be in the healthy pool now, but tomorrow it could be us. So it's really critical that we recognize that. And insurance only works if everyone participates and pays in. And again, I'll echo what I said earlier. I will need all of your help to reach everyone who lives and works in the district to make sure we get everyone covered.
Opinion. There are about 40,000 people who don't have insurance in the District of Columbia. And some of that is actually lowered by the fact that we have the Healthcare Alliance, which if we didn't have that, we'd have a lot more uninsured people, probably another, I don't know, 15, 20,000 people who are now covered by the Alliance. Do you believe the exchange, any one of you, jump in, all of you, do you believe the exchange is really going to help the 40,000 people who don't have insurance at present? And then what about those who are underinsured? Underinsured meaning that they may have an insurance program, but the deductible is so high that the game becomes, let me figure out how not to get sick because I can't afford to pay, the gap, the deductible, in order to be able to go get health care services.
Well, I can respond to that, at least first. It will reach some of them. I mean, the big debate when ACA was being passed was, if you recall, the importance of individual mandate to get everybody in the pool, and the young, healthy people especially. But let me pick up on what Mila said. A product that costs about $100 a month might appear to be very attractive from a price point of view. That product carries a $6,350 deductible. Now, if you're young, you're a young woman, you want your OBGYN visits and other things, you're not so attracted to a $6,350 deductible. Now, you may think that you're covered for a catastrophic illness. That is true. But I think people might think twice about saying, should I pay that for that kind of coverage? Because what I need every day, I have to now pay additionally out of my pocket. So let me step it up. Let's talk about a bronze plan, the lower level of what's on the exchange other than a catastrophic plan. Because if you recall, it's platinum, gold, silver, bronze. And it's very prescribed in federal law what each of those have to look like. But let me give you an example of what a bronze plan looks like. A bronze plan would typically have $3,500 to $6,000 deductible. It would have prescription drug integrated with the deductible, meaning if you went to your doctor visit and you got a prescription, it's not a copayment for the drug, it's in the deductible. You'd have 20 or 30% coinsurance, and you'd have a maximum out-of-pocket exposure of $6,350. That's a lot of cost sharing. And so if you want to talk about underinsured, is that underinsured? Maybe that's all in the eyes of the beholder, but that's a lot of cost sharing from most people. What's common in this market today is $1,500 to $2,500 deductibles, not $6,000 deductibles. And so what will the market do when it understands that to go, we think 80% of the enrollment will probably come on bronze and silver levels. And so, because that's the more affordable levels. But when they look at what the product is, they're going to say, my God, that's a lot of cost sharing. I don't know that I want to spend that money for that. I may have to spend $200 or $300 for a bronze plan, but then I'm exposing myself to another $6,350 out-of-pocket expense. That's not that attractive. I might want to pay a $95 penalty that's in federal tax law instead, you know? And we don't know. I mean, but that's what we will find out starting in 98 days.
Burning to jump in there.
Yeah, well, I guess another way to look at it. Yes, it is a, I agree with you 100%. Those are huge amount of dollars for a lot of people. But I think the question is, you may have a large deductible, but I want to pose this question of value. So I may have a cost-sharing amount that requires every time I go, I have to pay X% of something, and it adds up to this very large deductible. So that gets into the point. In Kaiser Permanente, we're both an insurer and a delivery system. So we think about these deductibles, and why don't you think about value? If, in fact, you come into our system, how likely are you to be referred 5 and 6 different places for consults versus one-stop shopping and one deductible or one co-insurance? So, for instance, I come in today, and I'm, coming in for whatever it is. I have blood pressure problems, and I have a spot on my arm. In a normal healthcare system, you'd get referred maybe to a dermatologist, right, to look at your the spot on your arm, and that you would incur another co-payment relative to that. Well, in the Kaiser system, you'd come in for your blood pressure check, and you'd get a consult right then with someone in the Kaiser system to look at the spot and not, incur another fee for service. And so the question is as you go into these, how efficient is your system so that you're not being referred 5 and 6 times, but you're getting everything in one visit and one co-payment. So, I think as this evolves, that will be the key, is you might have this much cost sharing, but how likely are you going to incur it with this system or that system based upon the efficiency of the visits, the way that, is it a fragmented fee-for-service system where you're really encouraged by the provider community to be, do more tests that maybe are unnecessary, which adds to the deductible. So, I think as we move along, that's what we really have to focus on. What's the total cost of care, and not just what your deductible is, right?
Yeah, I wanted to make a comment. I agree with those observations. I wanted to make a comment about the provider side, about the healthcare delivery system side, because just because you have insurance, it doesn't mean that you have access to care. So we have to look at the number of uninsured that then will be requiring services, particularly from the primary care physicians. Less so in terms of pediatrics, but in some areas, in certain states, in certain geographical areas, there is a shortage of specific kinds of clinicians. So we have to think of this in terms of the delivery system and to broaden it so that it's a team providing care, and so that we use the nurse practitioners and the physician's assistants in an effective way so that we can provide care to these patients that will be accessing our healthcare systems.
I want to comment. I think you made an excellent point because we've looked at our own experience here in the city, and yes, we cover 93% of our adults. Yes, we cover 96% of our children. But then when you look at healthcare outcomes, we have some of the most dismal outcomes, especially the further east you go in the city. So I think you're absolutely right in terms of it's not just a function of whether you have coverage, it's what is your access to healthcare services along the way. How do we improve that? Is the Affordable Care Act, the healthcare exchanges, are they going to actually drive the development of services, especially in areas of jurisdictions, this city, where we may have healthcare deserts, if we want to have a better way of putting it. And I'd like to hear from all of you on that, because the absence of service, what the heck difference does it make if you have healthcare coverage, but you don't have access? And for us, access shouldn't be that big of a challenge because geographically we're not that big. But there are other areas that are vast, cities that are much larger than us, counties that are much larger than the geography of the District of Columbia. Is the Affordable Care Act, are the healthcare exchanges going to be able to help to fill some of those gaps that exist?
Yes. So if we not only focus on the premiums and the insurance coverage, but we begin to make available publicly if I enroll in this particular insurer with this kind of coverage, how long will it take me to see a physician? What are my outcomes on diabetes? What's my readmission rate? What are my quality? I mean, there are many lessons and very successful off the Medicare Advantage program and the federal exchange that's available for seniors today, and that 5-star rating, and things called the HEDIS measures. Those are, I mean, as we build, the next iteration of exchanges has to not only be about product and price, but about quality and outcomes and access. And that's what this is all about. If we don't, that's healthcare reform, right? This is just creating a marketplace for choices. That the next iteration is what's going to be really exciting.
And if I'll just add, I completely agree with Kim's comments. I would just add that there's also a requirement for network adequacy. So in year one, essentially, all the health plans are making sure that they do have providers in the entire service area, which is the district, the entire district, not just parts of it. And we'll be monitoring that. So if we find out that your insurance card doesn't mean you actually have access to a physician that you need, we're going to come in and the exchange is going to establish standards to make sure that you can access a provider that you need, a specialist that you need. And so
how do we do that? I mean, I actually authored legislation when I was on the council to create incentives, tuition reduction incentives, that people have taken out loans to pay their tuition to go to medical school. And frankly, if they had stayed in certain areas, practiced in certain areas, they could have had their whole medical school tuition paid for over 4 years. I mean, it's a great incentive on its face, but it didn't drive huge numbers of people to practice, in the eastern areas of the city. Primary care physicians, we have out of, 700 to 800 in the city, we have 35 to practice beyond, on the other side of the Anacostia River, on the east end of the city, where we have 140,000 people. So what is it that we need to do? I hate to use the word drive, but to drive access to services in those areas that have historically been resistant to that.
I wouldn't minimize the impact of those programs that you have put, that you submitted legislation to that, because some of the physicians that work for me are beneficiaries of that and are now practicing in Southeast. I'm a product of the National Health Service Corps. I was a physician, and the federal government paid for 3 of my 4 years of medical school, and I was assigned to work in Wards 7 and 8 in the District of Columbia. That's how I started my career. So, it is an issue. It is a venue to get clinicians really engaged in working in some of those underserved communities. But we still have a challenge. There's still areas where the access to care is not what it should be. So, Children's, we're doing our part, but it takes much more in terms of a citywide strategy and initiative to be able to focus on that so that we can have the providers where we need them.
And I was just going to add.
I completely agree. I mean, we've told people historically, don't go to emergency rooms for routine services. Right. Well, what are they supposed to go to if there's nothing else? I mean, it's a great admonition to people.
Be clear. Be clear, we're there.
There's one of the hidden gems that we don't talk about enough is the investment that you made into community health centers. And right now there are community health centers in areas where you don't see private practitioners.
Right.
So the critical question, especially for the health plans here, will be, can they partner with some of those community health centers so the community health center can provide the access, the care that insured people.
How will the exchange facilitate that? It's a marketplace, obviously for people who principally don't have any kind of coverage. What can the exchange do to make sure that people not only get the coverage, but they also start to help fill in the gaps in services?
Mayor Gray, I think that goes back to education. Because the first thing that comes to my mind presently is what has happened in HIV education. Right. From where we were many years ago with HIV to most everybody here in the room now has some basic knowledge of HIV. And that same type, that we've had media communications over and over, the signs, the buses, all over about HIV. That same type of education program needs to take place with reference to preventative medicine, why it's important to do preventative, because so many of us will procrastinate until we have a heart attack, or we don't understand why it's important to go and get a checkup. And now if we have a system that allows us to access care so that we can get that frontline support, then we ward off these other higher types of expenses.
Is the exchange the avenue for that, Lee?
I think that it is going to be a contributor to that. The clinics, all of the outlets for medical care need to be about giving out this kind of information. And then the exchange can be used as a vehicle because of the network adequacy that Mila mentioned, having these things, addressing these things, but it's going to be a collaborative effort.
Yeah, we have to monitor network adequacy. So we have to make sure that when a health plan says they have active providers taking new clients in the particular area where they're at, that it actually is the case, and that the provider hasn't retired or died or moved away, and that the provider that's still there is accepting new patients. So we have a federal obligation to monitor that. And in year one, essentially working with all the health plans and the stakeholders, we've said, we'll see what happens. You tell us you have network adequacy standards and people can access care. So we've said, okay, prove it. We won't do anything, no new standards. If it works, great. If it doesn't work, we'll know from some of the data that's being collected from consumer complaints that we'll have, and we'll get together with all of the stakeholders and improve the network adequacy standards. And if we have to have standards around community health centers and contracting with other providers, we'll take a look at all of those options to ensure that at the end of the day, people can access care, that the insurance card that they have is actually meaningful. One other thing I wanted to mention.
You're next, Jet. I can see you just waiting to jump in there.
Say something.
Point I wanted to make earlier about the affordability. Based on the studies that we've had consultants do for us, we know that a significant portion of the 42,000 people without insurance actually will qualify for substantial premium reductions through the federal tax credit. And what that means is anyone up to 400% of federal poverty level can get premium reductions. In some cases, you'll pay half the premium that's listed. So you will pay half, and the federal government pays the insurance company of your choice the other half. So many people will, in fact, qualify for premium reductions. And of course, all of you know that small businesses and nonprofits can get tax credits if they are a certain size and offer salaries at a certain level. So there's substantial help available to for-profit and non-for-profit businesses as well.
You've been waiting patiently, Chad.
But in a sense, I want to speak to the question you raised, because I think it is a very important question. We have probably the broadest network of any carrier, by far. We have 40,000 doctors and others in the network. 98% of what we pay is in network. But you're raising a question about where there is no network and there is no provider. It's not a question of whether the provider is in the network. There is no provider. Mm-hmm. And we have found in our own giving, we have given millions to safety net clinics who basically exist with no revenue, except for federal support or community giving, because there is no other way to cover the cost. There's a theory behind, long-term, I think, behind the Affordable Care Act, and we will see whether it turns out this way, which is that if more people have coverage and therefore there is payment for the services that they get, it will stimulate the placement in underserved areas of physicians, particularly primaries, that otherwise wouldn't have gotten paid.
That is one of the theories. Do you believe that will pan out, or do you believe it will be a failed theory?
I am worried about it.
I think it will work. I think it will work.
Well, I assume everybody's worried about it. I'm just asking you to be a prognosticator at this stage, based on your extensive experience.
I'm worried that I think what Mila said is true. There will be premium subsidies and cost share subsidies. but there's still a lot of cost sharing in what the Affordable Care Act causes benefit designs to have. And whether people actually, with those cost-sharing amounts, get the primary care services they need remains to be seen. And it's hard to know in advance whether it will be enough to stimulate private physicians going into communities. They won't go if they feel long-term there's no financial viability to go. And so there has to be that viability to go. And I don't know that we know that yet.
We're actually investing in the city in the construction of new medical homes.
Yes.
We opened a new Anacostia clinic a little over a year ago, and we have under construction now one in Parkside, which is in Ward 7, and another in Ward 8, which is down in Bellevue. And the assumption is that people will go there because the services will be more accessible. But those services will have to be supported, and the assumption is that people will have insurance, to be able to support those services. I don't know. I think it would be morally reprehensible if we didn't make the effort.
Right.
But what if this doesn't happen?
Right.
What if it does? What do we do then? Anybody, jump in.
But, first of all, I think if we expect it all to be solved by independent private practitioners, it won't happen. But first of all, getting people covered, the accountability that's should be associated with the exchanges, organized systems of care, like a Kaiser Permanente, can make that investment and not leave these independent practitioners just practicing on their own in an island, but to surround them with the kinds of tools and to make it a meaningful practice, first of all, to have a peer, colleagues to refer to. We talk, you could think about network adequacy as the number of providers. I think the more important question is, how easy is it to get an appointment? How long does it take? In our system, every single day, we can tell you exactly how long it takes to get an appointment, how many people are in the queue. And we have a standard that's emerging now that we'll give people an appointment whenever they want it. And if they want it that day, a standard about, how many people that, beginning to improve our system, is it 80 or 90% of the people on demand can actually see a primary care physician or get a referral. There are lots of ways to solve this problem. Telemedicine. Do we need practitioners in every place, or is there a way to use technology, to lengthen the availability of specialists in areas that are underserved?
I don't know, but you got to be able to make sure that people understand how to use that technology also.
But you know what? There is much value in that, and I wanted to mention the issue of telemedicine. In rural areas of the U.S., that's one venue, that's one approach to providing services where you cannot necessarily have, very isolated communities. I'm not suggesting that that's the way it is in DC, but there are ways to use technology, to use telemedicine, to deliver services, as long as it's part of an integrated system of care. You can't have it in isolation, just an outpost. It has to be part of a system of care.
But you're right, that's not the challenge in DC, because if anything, we have limited geography, and still, even with limited geography, we have service deserts that seem to result in people not practicing preventive care and winding up with just dismal healthcare outcomes.
Kim, I just had a question as a thought, and I'm thinking in my mind.
I'm going to let Lynn jump in here also. She's been waiting patiently.
I was going to ask
Nice,
Mila.
Lynn.
The state of Massachusetts has had an individual and an employer mandate for a few years, and I know you've had those consultants working on all the different committees on the DC Exchange. And have they passed on any lessons learned? Because I think the experience in Massachusetts, the more employees and individuals got coverage, there were long waits for doctors and access
And the
to
wait
physicians.
increased. That's correct.
Right.
That is
So I
correct.
don't know if the consultants that you worked with
The
passed
wait
on?
for services has increased, is that what
Yes,
you're saying?
yes.
Even though people may have had coverage.
Because there was an influx of patients that needed primary care services,
Yeah.
and what happened, and the literature would suggest that it did increase the wait time for primary care providers. In
Well, it
that
helps
state.
you realize that the answer is just not in toto, is just not having health care coverage. You've got to have the services to go with it. I don't
that's
think
what
the
I was
master's
saying.
obvious, but
Absolutely.
that's exactly what we've seen in the District of Columbia. Even though we have a high percentage of our people covered, we have a high percentage of people in certain areas who are very sick also, some of whom are not that old.
Mayor Gray, I was going to ask Kim, I was just curious, what would it take for Kaiser to open more centers in the district?
People, right? I mean, so so the opportunity that we see with the exchanges is the more increasing number of people to actually make the choice for Kaiser. I mean, when we enroll 1,000 patients a day, we build a system based upon the access standards and availability that's required of those 1,000, and we build our system accordingly. So, we're not as significant as Care First in terms of the number of people covered here in the district today, although we made a significant investment in the district in terms of access and coverage over the last 3 to 5 years, as evidenced on our Capitol Hill, for instance, where as an alternative to emergency rooms, we actually, put together what we call a clinical decision support unit, which is a great place for 90% of what ordinarily would be in a congested, very expensive, albeit, incredible emergency room. So we have to rethink the design of the healthcare system so that we're taking, we're deploying our assets in less intensive at the right place. So, because we're connected electronically, we have providers that are practicing in teams. We get a certain number of patients in today. We begin to deploy the, system out with a commitment, measurement every single day, everything we do to make sure that we're hitting not only network adequacy, but access adequacy and outcomes. You come into our pharmacy today and the pharmacist will know what your blood pressure is, right? And will know what the doctor's orders were and can help advise you. Will know whether you had a mammogram. And if you haven't, they'll say, would you like one before you leave with their script? Those things, can happen in an organized delivery system.
I do want to.
I don't want to put Kaiser on the spot, but I will. I happen to be, by the way, a member. I live in Ward 7.
Yes.
Kaiser has a great facility on Capitol Hill. And then the further west I go, I can find more Kaiser operations. But the closest thing to me is Kaiser on Capitol Hill. Right. Why is there nothing on the east end?
The more members that we have, we'll be able to deploy the capital, the physical capital. So if we're really banking on, in terms of this exchange, more increasing number of people actually being able to select Kaiser, and we'll absolutely do that. In the past, and I think the 90% of people receive their coverage through employer-based coverage, which didn't allow them to pick a Care First or a Kaiser, right? You had to pick one system or the other. So, we, quite frankly, we're very, very committed to exchanges because we think increasing number of people will select this kind of a system, and as they do, Do
you think the exchange will facilitate the development of more services on the eastern end of the city? Because you're not only serving Ward 7 and 8, but you got a huge population of people in Prince George's County as well who are just across the border from 7 and 8. You think that's going to happen?
I think so. I mean, we're expanding in Prince George's County in July 8th, actually. We're doing a significant expansion to our Largo Medical Center. It'll be about double the size that it currently is, bringing in primary care physicians to a county that needs primary care physicians, additional access to, an alternative to emergency room. We have lots of capacity. And this new facility, and the reason why we expanded it was because of the outlook on the Affordable Care Act and exchanges.
So if I live in Ward 7, I go downtown, I'll go to Maryland.
Or we get more, and we'll have more facilities. I would also say that we also do support. We have about 17 nurse practitioners now that we deploy all over DC. Supporting the clinics that currently exist. So,
I think we're at the point now where we are going to take some questions, and how are we going to do that? You going to do the questions, Antoine? Okay, come on.
Mr. Mayor, do I get my fist pump? Thank you. Good too, man. Good too? Thank you. Thank you, Mr. Mayor and panelists, for that thought-provoking discussion. My name is Antoine Ford, President and CEO of Enlighten Incorporated, as well as this year's Chair of the Board of Directors for the Chamber of Commerce. And we would like now to take a few questions. I do have some. If you do have questions, you see now some of the Chamber staffers. Please pass it to them, and they'll take a look at them and send them to me. Okay, guys, we ready? I have a couple questions to start. The first one says, how will the DC Exchange work when workers live in other states but work in the District of Columbia?
So if the small business is here in the district, the small business can come to the exchange and get coverage for all its workers, not just the ones who live in the district, but also workers who live in Maryland and Virginia. The key is that the business is located here in the district.
Will people be able to use health flexible of Health Exchange savings account with the exchange?
You mean health savings accounts?
Yes.
Oh, yeah. I assume the exchange will have qualified high deductible health plans, so employees can keep or individuals could keep those.
Correct.
Is that true?
Yeah, no, that's correct. In fact, yes.
I'm trying to start something, so.
Yes, in fact, some of the proposed rates that the carriers have filed are in fact coupled with health savings accounts on the small group side.
What percentage of businesses do you predict will be offering coverage? This is where the mayor wanted some prediction.
So we've had consultants to help us figure out whether here in the district more small businesses will offer coverage than do today. And based on some modeling that we've had very smart people do for us, here we think job-based coverage will actually go up. I know we've heard a number of predictions out there that employers will just stop offering because it's just too hard, too complicated. Based on the modeling that we've done, we think more small businesses will offer coverage in 2014 and moving forward than do now.
Can you say a little bit more about the modeling?
I can say very little about the modeling. It considers the demographics of the city, the composition of the types of small businesses we have, the labor market, the economy, the growth, and then of course the ease of accessing coverage, the predictability in rates, and the reform marketplace. So all of those are built into the model, and the model actually looks at 2016 and beyond. So it's actually very difficult to measure what will happen in year one. So the model just essentially assumes 2016 and beyond.
Antoine, I was going to add, I think that there's also a consideration that has to be done to the business itself, the type of business that it is, and how profitable the business actually is. Because many times, if I run into a group that does not have coverage presently, the first question they're asking is, well, can I afford to do this? Because there's some minimal employer contribution that has to be added. So the rate is going to be impacted, but also the reason why they're not offering coverage presently. So if it's a rate driven, if this decision has been driven because I don't feel I can afford half of $400 times 10 for 10 people to cover them, then I may not choose not to offer coverage. Where if it's then my business is profitable, but I'm just kind of keeping that money for myself, then that's a whole nother different situation.
How are we going to prevent businesses from becoming more profitable since they can allow people just to pay the penalty and increase profitability? I'm a small business owner. Yeah. Small business owners are saying that, hey, wait a minute, I can increase my profitability.
Just not offer coverage.
And just pass it on to the penalty.
You're absolutely correct.
So
they're not doing that now.
Yeah.
I mean, most small businesses are offering it now, and they don't have to. They don't have to under the Affordable Care Act either. So my impression is that if you offer it now, you're not going to drop it, and you'll leave your employees exposed to penalties, which they'll have on their own tax return. And with the exchange, presumably, if it's easier and they can have more selection between carriers, you will get more businesses doing it. if they can afford it.
Correct. And I just want to clarify, so the Affordable Care Act does not require small businesses to offer coverage. It's completely voluntary for the small business to offer coverage. There is a requirement on large businesses to offer affordable coverage. And there's also a requirement on individuals to be insured. So if a person doesn't have job-based coverage and chooses not to be insured, the IRS will be knocking at your door. And that's the Affordable Care Act. Small businesses today offer coverage because they need to. They need to compete for that labor. The small businesses I've talked to who can't afford to offer coverage, it's not only the affordability piece, but it's also the predictions in year after year, the premiums jumping so much. So it's not that if you contribute $100 today, next year it will be $100, it could be $150, just from past experience. So that volatility for small businesses is very difficult to budget for. Because revenues don't increase 50% each year like some of the premium hikes do. So it's been difficult for some small businesses who want to offer coverage to do so because they can't predict what the premiums will look like. With exchanges, there will be more predictability and it will be easy to switch. If a policy goes up too high, the small business could choose something else very quickly, either working with their broker or doing it directly. So it will be much easier and much more predictable.
President Obama stated that if you like your current plan, you can keep it. Is this still true?
Yes, so grandfathered products, which are, if you, under the Affordable Care Act, if you have a grandfathered policy, which is a policy that you had in March of 2010, essentially you can keep it as long as the carrier continues to offer it. If you bought coverage as a small business after March 2010, that policy is not grandfathered. Or if you're an individual and you bought coverage after March of 2010, it is not grandfathered. What that means is all coverage that's not grandfathered will look different. The Affordable Care Act requires essential health benefits to be provided. The ACA also requires new rating rules. We talked about that, no more higher rates for unhealthy people. So all of that comes into play in 2014, and that's the ACA requirement. So all coverage will be different. But if you have grandfathered coverage, as long as the carrier continues to offer it, essentially you can hold on to it.
It's well to consider that about 2/3 of the market is not grandfathered, and that percentage will go up with the passage of time. So if you are an individual, let's just take individuals, and you're currently in a policy that you got after March 10th, 2010, you will be required to change your coverage into a product that meets the Affordable Care Act standards. And you will be required to pay whatever the new premium is, like it or not. So you can't stay where you are. If you're a small group and you're not grandfathered, the changes won't be quite as dramatic, but you will still not be able to keep the exact product you have. You'll be forced into another product with different rating rules, different coverage rules, generally speaking, somewhat more out-of-pocket expense. And this will hit small, I don't think if you were talking earlier about 40% of the American population not even realizing the law is still in effect. This will hit people as a total surprise, and it will hit small groups as a surprise. And that will cause confusion and consternation, and we'll see what comes out of that. But this concept that I think people have, that didn't the president say over and over again, if I like what I have, I can keep it? Not really, not for many of you. And that won't go down so easy, I think. And then as to premiums going up over time, the single biggest thing that makes premiums go up, other than the rise in the underlying healthcare costs, is what population did you attract? Did you attract sicker than average? Healthier than average? So if what happens, I'm not predicting anything, I'm just trying to explain the dynamic. If the exchange attracts somewhat sicker population, because the young, healthy people don't come in to the degree necessary. That will cause rises in premiums, like it or not. And so if an employer comes in and then gets hit hard in a second and third year because the risk pool on which the premiums are based is sicker, that is going to have a long-term effect on how well this works. We don't know. It's just unknown.
Wow.
And it's not possible to completely analyze your way into a conclusion because nobody has any experience with it.
I'd like to disagree with some of the points that you heard, strongly disagree. So for most people,
So this is getting interesting.
I was waiting for this.
For most people, especially small businesses, you know that your coverage changes year after year. It's very unusual that your policy stays exactly the same. So this notion that small businesses are not used to change, I just don't think it's true for most small businesses. Small businesses are used to choosing different coverage because they have to, because their current coverage becomes unaffordable because of the premium hikes, or they choose different coverage because they have different needs, or because their policy goes away. The carrier decides not to offer it anymore. So it's very typical in today's marketplace, year after year, to have a slightly different health benefit plan. And small businesses know that, and I don't think they can be fooled into thinking that their policy has never changed. I also think that there are other elements of the Affordable Care Act, which actually we didn't get into today, that will help prices to remain stable and make sure that the risk pools remain stable. We haven't talked about the 3 R's, reinsurance, risk adjustment, and risk corridors, and I'm not going to bore you to death unless you're an actuary and would like to get into that. But essentially, those mechanisms are there to make sure that in year 1, premiums are more affordable than they are today, even if you're not eligible for premium reductions, and longer term, that premiums stay stable. The other piece of the Affordable Care Act that I believe will help premiums stay stable over the long term is the idea that we're going to cover most of our population. So right now, there's this cost shift that we've all heard about and have experienced. The uninsured and underinsured people still go to the emergency rooms, get the care they need. No one denies them care and leaves them dead, right? The hospitals treat them. And we all pay for that care that they're not paying for directly. In fact, economists estimate that about $2,000 every year is cost shifted to us, the insured people, in higher premiums. And so once we get the entire population or most of the population covered, we'll no longer have that cost shift. There are medical homes, for example, another feature of the Affordable Care Act that's designed to keep premiums stable over the long term. So there are many aspects of the 2,000-page law that we haven't talked to that I believe will lead us to have stability in the risk pools as well as the premiums in the long run.
Last question I do want to ask, and this is interesting. Why did D.C. vote for a closed exchange when Maryland, Virginia, and most other states did not? I don't know if that's to my mayor or not, but anyone?
Okay, so we believe that, and actually I disagree with the word closed. In fact, what we did here is open up the market to everyone. So whether you are eligible for tax credits or not, you can have the exact same options as everyone else has in the one big marketplace. One of the reasons we wanted to make sure that everyone had the same options is the price transparency. And that is, if you require insurance companies to sell their coverage all in one web portal where consumers can see everything that's available, prices, different policy options, and compare and shop in a very easy one-stop way, that price transparency actually drives competition, and insurance companies are more likely to price their products in a way to attract new business. In fact, we are already seeing a success behind that. We posted, the insurance department, and we posted filed proposed rates for exchange products, all carriers, all of their proposed rates. And CareFirst and Kaiser came in at the lowest possible premium pricing. Aetna and United had higher rates that they were proposing. Just today, United announced that based on seeing their competitors' prices, they were refiling at least a 10% lower rate. I don't know what Aetna is going to do. They may refile lower rates. So already this price transparency is working here. And we believe that price transparency will also ensure reasonable prices for individuals and small businesses.
I think I'll just add, as we were, I think a lot of us in the broker community have been very active in the whole discussion of the closed, or however we want to term that marketplace. And when I first started all of this, I was totally against a closed market. As I got a little bit more information, specifically because of the size of the District of Columbia, meaning that we're not the state of Texas, for example. We're not the state of California in terms of size. So, in having a sustainable pool, there was a thought process that maybe we needed to try to have some way to make sure that the exchange would be successful with reference to that. So, I slowly started changing my thought process a little bit in terms that maybe it's not such a bad idea to have this marketplace, but where I differed was how long it would take to take place. Since the marketplace, the exchange, and all this has already been decided, so this is water under the bridge, but since the marketplace hasn't been operational yet, should we change it sooner rather than later, and not allow time to see how the exchange would work? So, as I said, that decision has now been made. The market will transition to the exchange in the small group market in January of 2015. So if a group presently has coverage and you renew in 2013, you can renew your current coverage to 2014. You can renew it again in 2014 if you choose. And then when you renew in 2015, you will be going to the exchange. And so part of the discussions about the pool and whether we were attracting the healthy or the unhealthies, that will slowly take care of itself, because in 15, everybody in the small group marketplace is going to be in the exchange. So that's just a little bit of information about how I, as a broker, kind of came to this particular situation. Now, true, all of the other jurisdictions have a dual marketplace. They have a private and an exchange and a private market, if you will. But we're dealing with size. You know, you look at Vermont, you look at Rhode Island, you look at the District of Columbia, you've got very, very small areas, and the exchange has to have enough people in it to be successful. So while, as I said, I started out one way, kind of came to the middle of the road a little bit, and viewing that there was some benefit to having this for the exchange to be successful, because that's the key. Is for the exchange to be successful here in the District of Columbia.
Just one point of clarification. I'm sorry, go
I'm
ahead.
going to make one small clarification.
Please.
If your plan is grandfathered, you do not have to renew in the exchange in 2015. So as long as your medical plan remains grandfathered, and that's always comparing your plan benefits and what you contribute towards coverage back to March of 2010. If you haven't made certain plan changes, like increasing your deductible or increasing the percentage that employees pay towards coverage, and you've been issuing a grandfathered plan notice to your employees, you would not have to renew in the exchange as long as you remained grandfathered.
And I'll just add there, the key there is issuing that notice and taking those steps to be grandfathered. And we're finding that many groups who thought they were grandfathered as of March of 2010 did not follow all of the procedures correctly. So they may have thought they were grandfathered, but they can't produce a notice that they've been providing to their employees. So that has to be looked at very carefully as well.
Yes, so you wanted me to talk a little bit about what closed and open and the terminology?
Just close and open.
Okay. So essentially, in many states, especially high population states, marketplace exchanges are being established to serve a particular population, and the rest of the commercial market remains outside of the exchange. So there are different ways that small businesses and individuals can access coverage. Now, if individuals need premium assistance, premium reductions, or small businesses need tax credits, under the ACA, they have to purchase through the exchange. Otherwise, they can go in either place. For us, we wanted to make sure that we weren't creating a dual system of people who need help and those who don't. We wanted everyone to have the same access. So DC HealthLink is our web portal, and when people talk about the exchange, it always amazes me that it takes on its life of its own. It's a web portal. It's a tool for consumers. That's all it is. There's a web portal that brokers will have, and there's a web portal that small businesses and individual consumers will have. Just like and I don't want to compare shopping for health insurance to airline tickets, but the concept behind Expedia and Kayak, you see all the prices in one place. That's the idea. Consumers and small businesses go to DC HealthLink and see all the products, all the prices in one place, as opposed to having to go to different distribution channels, to different ways to shop for coverage. It's really a way to help consumers be smarter shoppers, one-stop shopping, and also will serve very well the broker population who will be working with us. And I should note that Lee is on our advisory, one of our advisory committees, and has been helping us with a number of issues that we've been tackling.
Thank you guys so much for the questions. I know we didn't get into all of them, but this was such a great discussion. I wanted them to go on. It's my pleasure right now to introduce Robert Summers from the Office of DC Small and Local Business Development, who closes us out. Robert's a great supporter of the Chamber, and I appreciate it. I'm getting used to introducing him now since he does such a great job of supporting. Robert?
Should I give you a fist bump too? All right, there we go. Thank you, Antoine, for those kind words. And thank you, Mayor Gray, and our distinguished panel. I think you all would agree that this was quite a discussion, and I'm sure we will have some carryover afterwards. Some of you had some questions that didn't quite get answered, but I think our panel will stay a little bit afterwards if I'm not obligating you guys to answer some additional questions. So I would like to thank our panel once again. Very informative, so we can give them a hand. I would also like to thank Mayor Gray for his leadership. He talked a little bit earlier, and I won't waste, well, I shouldn't say waste too much time. I won't talk too much about how DC has grown, but it should be noted it didn't happen by itself. So thank you, Mayor Gray, for your leadership. I would also like to thank our sponsors. We would like to thank Care First as our presenting sponsor, and CVS as our legislative sponsor. So thank you for our sponsors. I'm also proud to represent the DC Department of Small and Local Business Development as today's forum sponsor, so I will thank myself and the this is quite a discussion, and that I'm sure we will continue at tonight's reception. And for many days to come, I'd like to thank all of you for attending today. Your attendance once again shows the energy and dedication of our business community and the tremendous support of the DC Chamber of Commerce. The DC Chamber of Commerce is a valuable resource in our community. Just look at today's panel. To be able to bring together this group of powerful minds to educate our local businesses about something as complex as the healthcare reform is amazing, and reaffirms the DC Chamber's commitment to helping you navigate the ever-changing business practices. However, the evening's not yet complete. I hope you can all join us at our post-forum reception. We will keep the conversation going, network, and enjoy each other's company. But one final note, too, as Mayor Gray pointed out earlier, I guess we're chasing Houston. Is that what it is to be the hippest city? So bring some of your suggestions to Mayor Gray, and I think part of this fist bump can help us along that way. So thank you very much. Okay, thank you.